Thanks so much, Tom. Good morning, everyone. This is my first official event, I think, if I'm thinking back correctly, as the new Associate Scientific Director of Population Health. So I'm very excited that this is an opportunity that I get to participate in. My role this morning is to help moderate our first panel. I'm very excited to be here, supporting and speaking with a panel of very accomplished researchers working in some very interesting and diverse spaces. Our first panel of the day will be talking about their work related to COVID-19 and the implications of using and influencing policy and practice with research. We'll hear from each of our panelists, like Tom said, 6 or 7 minutes each, and then we will have 20 to 30 minutes for some questions, which I'll help moderate as well. So please take advantage of the expertise and the intelligence that we have with us this morning and post your questions in the Q&A section at the bottom of your screen. And I'll do my very best to bring those questions forward as best I can. Hopefully we'll have lots of really good questions this morning. It is my pleasure to introduce our first speaker this morning, Dr. Sofia Ahmed. Dr. Ahmed has done a ton of work working in gender-based analysis related to kidney and cardiovascular health, but also related to diversity in academia and COVID-19 mental health and healthcare workers. So I'm very happy to welcome Sofia for our first discussion. Our full bios for all of our panelists will be posted in the chat if you'd like a little bit more information about each of our speakers. So I will turn it over to Sofia.
Great. So thanks very much, Dr. Milaney, and to the organizers. I'm delighted and honored to be part of this outstanding group today. So I'm here to talk to you about gender in the healthcare workforce in the pandemic. And next slide, please. And so clearly we've all been very much affected by the pandemic, but to use a binary in terms of talking about gender, because that's where most of the literature is. Next slide, please. Men have had more direct effects of the pandemic. So they're more likely to have gotten sick enough to get to the hospital or to be admitted and to actually die as a direct consequence of the virus. Next slide, please. Whereas women have had more indirect effects of the pandemic. So next slide, please. Decreased access to reproductive services, increased rates of domestic violence, and significantly increased financial insecurity, largely due to job loss because of childcare needs. Next slide, please. So have there been gendered effects of the pandemic response on the healthcare workforce? So a collection of us here at the University of Calgary, in conjunction with our collaborators, healthcare workers across the country, got together and asked ourselves that question: what is the effect of the pandemic on the healthcare workforce? And I would like to highlight Dr. Milaney as the first author on this, who was a PhD student at the time and is now a medical student here at University of Calgary. Next slide, please. So this again is our question. Did the effect, or does the emergency response to the pandemic, did it affect us differently depending, as a healthcare worker, depending on our gender identity, our gender roles, and our relations, and really who we were or are? Next slide, please. So this was a survey that we launched. We contacted as many healthcare worker organizations across Canada directly via email, as well as through social media, Twitter, Facebook, etc. Next slide, please. And we, just to give you an idea when we actually launched the survey. So this is a timeline of the first year of the pandemic put out by Yale Medicine. Next slide, please. And you can see here that this is where the world shut down on May 13th. And, you know, this is when school shut down, daycare shut down, everyone was told to stay home with the exception of essential workers, which included clearly healthcare workers. Next slide, please. And so you can see, and so this is when our survey was done. So shortly after that time, when people were still adjusting to what I'll call the new normal. Next slide, please. So in the end, we had a fantastic response. So over 2,000 respondents, representing 63 different types of healthcare workers. The majority or most respondents identified as women, which is perhaps not, it is not unremarkable, given that 70% of the healthcare workforce globally is identifies as women. The most common types of healthcare workers who responded were, in descending order, nurses, physicians, and pharmacists. But as you can see, we had a wide breadth. Next slide, please. So one of our first questions was, were you asked to take on, or rather, did you take on a new leadership position in terms of pandemic planning? And you can see that 13% of women said that yes, they had. Almost 20% of men said that they actually had assumed a new leadership position. Next slide. But what I think is also important to recognize is that the vast majority of healthcare workers said that they had absolutely no involvement in any level of pandemic decision-making. And this was more common response in women healthcare workers compared to men. Next slide, please. So this slide, it just shows, we asked healthcare workers about their home life and what the effects of the pandemic planning and the workforce planning had on their home activities. So up the top here is childcare. The middle graph here are caregiving of adult dependents. So this might be older relatives, elderly neighbors. And on the bottom here are household activities. So cooking, shopping, cleaning. And to your far left on the x-axis is severely increased, and this goes all the way down to the right side of the x-axis, so severely decreased. And I just we had so few people who identified as not cisgender that for the interest of time, I'm not sure how representative the responses are. So I'm going to focus on just women and men cisgender women and men. So this black bar here on the left represents women, and the lighter bar beside represents men. And you can see, next slide, please, that for all of these activities, women said that they were spending either somewhat increased or significantly more increased time on all of these activities. Next slide, please. We lastly asked about anxiety levels. And so we said in January 2020, so before the pandemic was really on anyone's horizon, what were your anxiety levels like? And this is using a validated tool. And so there were no gender differences according to the responses to these 6 questions for that particular question. Next slide, please. But when we asked, tell us about your anxiety levels right now, the levels of anxiety were significantly higher across all 6 questions in women compared to men. Next slide, please. And they were significantly even more higher in women who had children under the age of 10. Next slide, please. We finished off our study by inviting all 2,000 respondents, or anyone who responded, if they would like to participate excuse me, in a one-on-one interview to tell us more about their personal experiences. Next slide, please. And in the end, we had 46, by the time we had interviewed 46 respondents, we'd reached saturation of themes. And really, these were the 3 things that recurrently came up, that people felt that depending on one's gender identity, people were offered or not offered leadership opportunities. And that there really were very few workplace supports that were put into place, and that the ones that were there, and because of that, this disproportionately negatively impacted women's performance and ability to come to work. And then lastly, that there was a disproportionate increase in household responsibilities that were influenced by previously existing gender roles. Next slide, please. So really what our study touched upon is that there truly are, not surprisingly, very much gendered effects of the pandemic response that affect healthcare workers differently depending on their individual roles, responsibilities, and identity. And I think what we want to take away from this study is that a high-functioning, effective healthcare workforce is central to pandemic control. And so going forward, we need a gender transformative strategy that takes into account individual needs and responsibilities in order to optimize both the health of the healthcare workforce, which optimizes the health of us all. So thank you very much.
Thanks so much, Dr. Ahmed. I look forward to talking with you more when we get to the Q&A session. Just a reminder, folks, please do put your questions in the Q&A box. Next, it is indeed my pleasure to introduce Dr. Pam Roach. Pam Roach is a very good colleague of mine. I'm very happy to say that. Even though we work in different departments, our paths cross all the time, sometimes with students and sometimes just when I need some really good advice. I'm currently enrolled in the +4 Reconciliation Leadership Program with Pam, and I highly recommend it to all of you. There'll be another session in the fall, so please check it out. Pam has done some really interesting work related to healthcare and Indigenous communities. So I'll turn it over to you, Pam.
Thank you. And thank you everyone for joining me this morning. And I was really pleased to be able to be here. You can see, just want to acknowledge that I am talking about some work around virtual care this morning, but all of the people who contribute to that, including everyone from the Indigenous Primary Healthcare and Policy Research Network, from Alberta Health Services, from the Alberta Indigenous Virtual Care Clinic, and from our funding body, which is CIHR. So if we move ahead to the next slide, this is a story that I think, we just heard and we all are pretty familiar with, but I'm going to be talking a little bit today about some virtual care work. And so just kind of setting the scene, we know that in Alberta, our first case of COVID-19 was identified on March 6th. And then there was a series of shutdowns and services going online. What we did see was an immediate need for ongoing Indigenous primary health care. And so that shifted in many instances to virtual options and virtual delivery. And then the Alberta Indigenous Virtual Care Clinic actually opened as a result of the pandemic. So we applied for a bit of funding to do some work. So if you go ahead to the next slide, there's the objectives of our project are really to understand how do Indigenous patients accessing virtual care or remote-based primary health care during the COVID-19 pandemic define high quality virtual care. So how do those aspects of good quality care for Indigenous patients manifest in a virtual setting, and how can we ensure they're there in a virtual setting? And then how can we actually measure and monitor that? So if you go ahead to the next slide, I'll just tell you a little bit about the things that we looked at. So in some of the activities that we did. So we had phase 1, which was really looking at developing Indigenous indicators of high quality primary care. So we did a rapid literature review around what was already existing, and then use that to guide a framework analysis through semi-structured interviews with Indigenous patients who had either accessed virtual care through a virtual only service like the Alberta Indigenous Virtual Care Clinic, or who had previously accessed their care in person and had their care switched to virtual appointments throughout the pandemic. So anybody who had accessed care through the virtual clinic or through Elbow River Healing Lodge since the start of the pandemic was eligible to participate. And we really wanted to explore the experiences of that accessing virtual care. We also spoke to some virtual primary healthcare providers to develop some key domains and indicators of healthcare quality that were relevant to all stakeholders. So developing some frameworks and some understandings that are really grounded in Indigenous voices, but also understanding that there will be priorities for people within the health system as well. So if we go along to the next slide, we started looking at how do we take those key domains, those key characteristics of high quality virtual care for Indigenous patients to create a patient experience tool that then we can use to measure and monitor that. So some themes that were coming out that we expected were things around access, relationships, and trust, time and travel, improved follow-up, and self-maintenance of health. So then we had to think about, well, what do these domains look like in practice? Specifically for Indigenous specific services, increased safety, the ability to give feedback from patients to the service itself. So what we heard, we'll start out on the next slide. I'm not going to read out all of these quotes, but the first key domain really being access and thinking, not only was it same day or next day appointments with a primary healthcare provider, but that certainly for people who live in more remote communities, being able to access a care provider so quickly when typically like perhaps people had to take a day or 2 days off just to travel to the appointment and see the physician and come back home. That made a huge difference with access, and just knowing that people will understand their experiences and have some knowledge of Indigenous healthcare. The next slide speaks to relationality. So being able to talk and not get frustrated from not being heard, not feeling judged, not feeling stigmatized. And that's very, very interwoven with things like access when we think about, is a service not only available, open, and in a location you can access it, but is it actually safe to access? And so are the people accessing it because they do sense that they won't be judged or stigmatized or experience racism while they're there? And then on the next slide, talking about quality and cultural safety. So knowing that the healthcare providers actually have knowledge of Indigenous people, of colonization, of health impacts. You don't have to explain intergenerational trauma. It does lead to that more robust sense of safety. And then on the next slide, just to talk a little bit about the things that have happened since. So we heard all of these things. We were creating these key domains, but really needed to continue to make sure that this was relevant to everybody. So did some adapted nominal group technique to co-develop a tool with an Indigenous reference group that we had developed and pulled together at the start of the study. We did some cognitive interviewing, which is testing the tool to make sure that the questions that we're asking are being understood as we're hoping they're going to be understood. So that's less about piloting the tool and more about kind of deconstructing it with patients. We did collect some additional qualitative pilot feedback from patients and providers, and then we'll be continuing to refine it. And then if on the next slide, I'll just show you, this isn't the complete tool, which we've called ARCs for access, relationality, quality, and safety, but a few examples of some of the questions. And so some of these questions are based on important bits of information for the service to know, but largely grounded in what does a meaningful virtual care experience mean for Indigenous patients. And so we've got a tool there that we will be looking at implementing next. If you move on to the next slide. The future directions, we were successful in getting a second CIHR operating grant. So that one is currently underway, and that's a close partnership with Alberta Health Services and the Indigenous Virtual Care Clinic. So what we're going to be doing there is actually implementing and getting the infrastructure set up so that we can embed the patient experience tool into the ongoing clinical quality improvement for the virtual care clinic. And then also developing some supports for healthcare professionals who will be sort of receiving the reports and the measures. And so that we're not just providing some feedback, or patients aren't providing feedback with nothing to do. So developing some clinical supports for that, and then are going to be evaluating the actual implementation of it. Further work, there has been some conversations with community who are interested in where virtual care can also support Indigenous patients in other ways. So this is really focused on a broad primary healthcare approach, but there's specific sort of healthcare settings and clinical contexts where we suspect that virtual care might be very advantageous and help improve both individual and population health outcomes. So we'll be exploring that further as well. So I'll stop there and hopefully get to answer some questions in a bit.
Thanks so much, Pam. It's interesting to hear about positive experiences in terms of people accessing virtual care. So I look forward to hearing more about that in our Q&A section. Next, we have Dr. Jean-Christophe Boucher, who is a colleague of ours here at the University of Calgary from the Department of Political Science. We haven't actually met before this morning, but I did recently have a look at one of your papers on attitudes, behaviors, and barriers to public health measures during COVID-19, and some of the conflicts that I think we all felt around public health messaging and the role of social media. So really looking forward to hearing what you have to say this morning, and over to you.
Great. Everyone can hear me. Thank you so much for the invitation. I'm in Riga, Latvia. My Wi-Fi is surprisingly sketchy, and I'm participating to a NATO conference on Russian disinformation. So hopefully everything will stay put, and I'm more likely to see what's going to happen. So I'm not seeing my slides. up. So part of the research that we've conducted at the School of Public Policy was stemmed from partners out of AHS and from the MHOs and CMHO who wanted us to help them design and evaluate a social media campaign that would address vaccine hesitancy amongst young Canadians. And the argument that we saw at that time was that they wanted to engage further into the social media space, which AHS didn't and still really doesn't have a real capability. And so through an Alberta Innovate grant, we essentially designed an entire intervention evaluation experiment, essentially collecting millions of tweets every week since November 2020, and then systematically every week through social network analysis and machine learning applications, provide expertise and provide to AHS partners a clear understanding of narratives and justifications, especially trying to measure specifically how anti-vaccine conversations evolve on social media. So as part, it was part preventive, trying to address and understand what was happening, but also part trying to help the communication strategy. So like I've said, we've collected, we had essentially a scraping API designed to collect millions of tweets out of Twitter. On a good week, bad week, we collected about 10 million tweets, 20 million tweets a week. Our entire data set is about right now 500 million tweets across 2 years of pandemics. And from there, what we did with the tweets is basically build what we called retweet networks. So essentially trying to understand how people on social media, people on Twitter would interact with each other, essentially trying to understand networks of conversations on social media. So essentially what we're trying to do is identify vaccine hesitant groups that would and then be able to kind of isolate them in a network. It's extremely difficult just from a brute force approach to identify and really measure misinformation on health policy. So that's perfect, Liz. All right, so and so what we've done is so we collected those tweets week in, week out. And then we create these network maps, which allowed us to do different things. On the one hand, it allowed to isolate anti-vaccine communities, essentially groups of accounts on social media in Canada, but abroad, that would promote anti-vaccine narratives. And from there, kind of identify not only the influencers in this space, really looking at content creators who created content on anti-vaccine, who promoted misinformation vaccination, but also being able to identify Canadians' accounts and who participated in Canada in that group. From those, we could isolate groups of accounts associated or in interaction or daily interactions with anti-vaccine major accounts. And from there, we essentially built a natural language processing machine learning model or pipeline that would do several things.
So I'll ask Dr. Stephana Moss to join us next. Dr. Moss is an epidemiologist in the Department of Critical Care Medicine here at University of Calgary and has done some great partnership work with citizen researchers and has done some really interesting work looking at critical care and intensive care and experiences of caregivers in those situations. As well as the socioeconomic impact of COVID-19, including on children. So again, Dr. Moss, thank you so much for being here, and we'll turn things over to you.
Thank you very much, Dr. Milaney, for the opportunity to participate in this timely and relevant discussion. Today, I'll be speaking about the socio-cultural implications of the COVID-19 pandemic and how our program of research in this area has impacted meaningful public health policies and programs. So all programs of research that I will speak on today are led by Dr. Gina Parsons-Lee, an assistant professor and Killam Memorial Chair at Dalhousie University, and the established and bright individuals that comprise the Health Knowledge Mobilization Lab at Dalhousie University. Next slide, please. The Health Knowledge Mobilization Lab, we were very fortunate to receive 3 separate but related Tri-Council funded grants to explore the socio-cultural implications of the COVID-19 pandemic, vaccine hesitancy, and pandemic recovery for youth and their families. Working with researchers and stakeholders across the country, our goal is to build a pandemic preparedness hub to ensure that we learn from the experiences of the last 2 years that we've all been through and ready ourselves as best we can for future public health crises. Next slide, please. So the structure of each project in our hub is similar. Each project is based on a review of existing evidence as well as partnering with stakeholders to identify where the gaps in our pandemic response were and an understanding of the varied and multifaceted implications of those gaps, and finally, development of evidence-based health system and policy embedded solutions. Next slide, please. So when we first started on this research, we were focused primarily on supporting adults in the general public. Since then, however, our research has grown into a multi-arm program that includes a broadened focus on vaccine hesitancy in Canada, as well as on youth response and recovery to pandemic events, with an eye to how supporting this very vulnerable population will benefit youth individually, while also having positive implications for society more broadly. So in the following slides, I will speak to the aims and the policy implications of each of these 3 programs of research. Next slide, please. So the very first grant as part of our pandemic preparedness hub was aimed to hone a deeper understanding of the social and cultural dimensions of the COVID-19 pandemic. We rapidly assembled a multidisciplinary team of clinicians, members of the public, knowledge users, including health delivery and non-governmental organization decision makers, as well as researchers, who were tasked with co-designing population-level and system-based solutions to support public awareness related to the COVID-19 pandemic by identifying and closing important knowledge gaps. Our ultimate goal was to educate, engage, and empower members of the public to be informed stewards of their health literacy during the COVID-19 pandemic and beyond. Next slide, please. So this very large body of work contributed 4 unique papers, including 4 stakeholder groups to our evidence base. And these works informed our knowledge translation campaign that was partnered by Knowledge Translation Canada and the KT Committee of the Canadian Critical Care Society, in which we developed policy and programming recommendations to combat misinformation, discrimination, and fear to improve public awareness, knowledge, and trust during the COVID-19 pandemic. These included the recommendations that public health messaging should target domestic news sources as key disseminators of knowledge, as respondents in our study viewed news sources as equally credible to public health agency websites, and the critical need to consider demographic characteristics in tailoring the format and information medium to improve large-scale acceptance and uptake of mitigation and containment measures in an infectious disease outbreak. As we know, at times of crisis and beyond, public health recommendations need to extend simply beyond how to prevent infection. Next slide, please. So the second grant that we received, this was really critical for us to ensure a deeper understanding of the drivers of vaccination decisions across population subgroups, as well as the healthcare workforce. So through both our ongoing pan-Canadian as well as our completed global programs of research, we generated rich quantitative and qualitative evidence to understand and combat primary drivers of vaccine hesitancy and to inform effective communication of vaccine recommendations. Our primary aim for this program of research was to develop targeted stakeholder-driven solutions to build confidence and maximize COVID-19 vaccine uptake and beyond. Next slide, please. So the policy implications from findings on our completed global program of research, these were particularly impactful, and I will speak to those here. So we surveyed just over 3,000 healthcare workers across 23 countries, and we found that 1 in every 6 was vaccine hesitant, and that concerns regarding safety, distrust, efficacy, and risk increased the odds that a healthcare worker was vaccine hesitant. In collaboration with the Barcelona Institute for Global Health, the City University of New York, as well as the Canadian Centre for Vaccinology, we suggested to policymakers that multi-pronged education and behavior interventions with messaging that emphasizes vaccine safety, with clear, consistent, and comprehensive information describing the science and rigorous review process underpinning vaccine development could improve vaccine acceptance among healthcare workers. Next slide. So why did we think that the expansion of our pandemic preparedness hub to include work focusing on youth was so important? Well, we found that national data from Statistics Canada showed that a top concern for Canadian parents throughout the pandemic has been balancing childcare, schoolwork, schooling and work, with about 75% of participants reporting feeling very concerned or anxious in this regard, which likely stemmed from increased demands in the context of decreasing external supports. So in response to this, the overarching aim of our youth and family focus project is to rapidly identify underlying drivers of stress and trauma due to the pandemic, as well as associated protective mechanisms in diverse populations of youth and family in Canada. And this will help us shed light on how we can best support families throughout the pandemic recovery and in future health crises. Next slide, please. So our ongoing child and youth focused program of research of work, including 3 families as primary applicants, is centered on understanding the multifaceted impacts of the pandemic and related policies on the well-being of Canadian youth and families to promote well-being and decision-making, and to inform public health policies relevant to this priority population. So to facilitate the effective dissemination, uptake, and retained memory of our work, we have partnered from inception with 5 leading organizations in Canada to directly inform their policies and programs. The policy implications from the knowledge synthesis phase of this program of research that has already been completed included that legislation, policy, and programming should be evidence-informed, data-driven, and reflective of need. We also recommended that improving all aspects of youth well-being will require increased availability and access to quality data across sectors. We've seen that while actions aimed at single issues are necessary and may seem simpler to implement, systematic change that upholds fundamental child rights will lead to sustainable improvement in the overall well-being of all children and youth. Next slide, please. So really the take-home message from these 3 programs of research, we found that the drive behind our pandemic preparedness research is really the knowledge that blanket policies and recommendations, they may work initially, but they're very hard to sustain. We also know that effective policy is evidence-informed and considers socio-demographic differences. Our work uncovered stark differences in drivers of pandemic behaviors within diverse subgroups, and these differences must be understood and implicated in our policies and programs as we look towards pandemic recovery. Next slide, please. So just taking a second to acknowledge our extensive network of funders, collaborators, and community partners for supporting and engaging in this work over the past 2 years. Thanks very much.
Thanks very much, Dr. Moss. We have not been able to reconnect with Dr. Boucher, so I think we will go ahead and move on to our Q&A session with our first round of panelists. I invite you all to please turn your cameras on so we can see you. Excellent, thank you. So there are a couple of questions in the Q&A, but as I'm going through those, I wonder if I could start us off with a question specifically related to research and influencing policy and practice. So I'm curious to hear from each of you why you think it's important that researchers are even talking about or thinking about using research to influence policy and practice. Does anybody want to start us off with some thoughts on that?
I can start.
Thank you.
Sure. Yeah, so I think every the pandemic, if nothing else, we can think of it as a learning opportunity. This isn't our first learning opportunity to see, I'm going to speak from a healthcare workforce perspective, how well or not our planning works. We've been through this through Ebola, maybe not specifically in Canada, but certainly globally. So the Zika virus, every once in a while, there's a flu epidemic. And so we've been through this before, and a lot of what I presented today is, I don't want to say it's not particularly novel, that's not what I mean at all, but so for example, in Ebola, people did not take into account that I told you that the majority of healthcare workers identify as women and are also the primary caregivers at home. And so Ebola was actually propagated because women who were nurses would then go home and care for their children. And so their families would then test positive for Ebola. And so that type of family, or sort of the gender roles, were not taken into account in terms of planning, in terms of pandemic healthcare workforce resource allocation. In the Zika virus, access to reproductive health services were shut right down. And so as a consequence of that, and who was most at risk of Zika virus? Well, people who were pregnant. And so through planning or perhaps, I don't want to say lack of, but inadvertently, we propagated the pandemic, or in that case, it was an epidemic. So I think a shift has occurred in terms of that and perhaps because the COVID-19 pandemic has affected the world, that it's a great learning opportunity. Let's see what worked well, let's see what didn't. We'll study it. And this is a great example. I'm so impressed by what people have reported today in terms of the research they've done. Let's use it and improve outcomes for everyone. So I'll stop there.
Mm-hmm. Yeah, thank you.
And I can just hop on to what Dr. Ahmed said about, why is it important for us to think about policy changes? Well, I know for many researchers, policy change really is the ultimate goal as we strive to share findings that have tangible impacts in important areas, and most often areas that we're quite passionate about. So when considering policy changes, this deliberate change is really the first thing that comes to mind. But in research, it's equally important to consider the impacts on these changes on groups beyond the primary subjects of the research that we're conducting. So like which voices may be missing and what perspectives might they bring? How will this shape policy? How will this policy change help to support certain groups? What are the impacts that these changes might have on individuals outside these groups? These are some of the questions that typically come to mind to researchers as we're thinking about moving our findings forward into policy. So for example, in the COVID-19 pandemic, as Dr. Ahmed mentioned, we saw that increased rates of loneliness in many hospital patients. They experienced this when visitation was restricted during the COVID-19 pandemic. So this is just an example that while it's impossible for us to predict every potentially negative outcome associated with any given change that we suggest for or recommend for policy and programs, it's also equally important for us to be aware of the wider impact of our findings, both intended and unintended as well.
Mm-hmm. The unintended is a big one for sure. Yeah. Pam, did you want to add?
Yeah, so I think, there's great comments already. For me, it's quite straightforward in that when I'm doing work and I'm, undertaking research, and my goal is to ultimately improve health outcomes for Indigenous patients, right? And Indigenous communities. And it's an obligation of doing the work, is that if I impact practice and services or I impact policy, that there has to be a reciprocal outcome, that will improve healthcare in some capacity. So for me, it's quite a foundational piece of the way I do research, and that commitment and obligation to the communities that we're trying to serve. So I think whenever I think about planning work, it's sort of like, what is this? So what is the outcome? And if there's no outcome, I need to reorient my thinking, and I need to connect back to the people it's going to impact so that we do have a relevant impact and outcome for people.
Mm-hmm. The so what question is the big question in terms of why are we doing this and for who? Yeah, thank you. We have a couple questions in the Q&A. A question maybe first for Pam. Is virtual support / care potentially a risk to resources that are needed to help fund physical infrastructure and in-person care in remote or underserved areas? That's a big question.
That's a big question. It's a good question and it's complex. So what I would say, in an ideal world, I'd like to think in a non-competitive way and that there's so much need, but also realizing the realities of the fact that we work within a system that has resource limitations. But I see this more, the virtual care work, the way it's set up is that it's not replacing that in-person infrastructure and those kinds of clinic settings, but what it is doing is filling a gap that doesn't exist. And so for many of the people who are accessing, because it's primary healthcare, there's a lot of people who are unattached to a family physician who may not be able to get a family physician. And so they will contact the virtual care clinic specifically. And I think because as the work has evolved, it's been more and more sort of embedded within the virtual care clinic practices. But essentially what we've been hearing is that people see the clinic, and I think there's a role to play there around finding and attaching people to family physicians, but they're almost seeing the virtual care clinic as this virtual medical home. And so but even though they might not have provider continuity because they can't guarantee they'll have the same provider every time they use the virtual clinic, people are using the clinic more than once and they're almost seeing a clinic continuity with the virtual clinic. So it's sort of filling a gap and meeting some needs there that help support those more in-person facilities, right? And so this is providing probably a broader foundation to the provision of primary care, and understanding that primary care and family medicine is really that foundation of the health system. So the more we can build up that foundation in whatever ways that we can do creatively, hopefully has then, other impacts on the rest of the system too.
You made an interesting comment in your presentation around, some people having to travel a day or two just to get to see a physician. And so it seems like this could be also filling a gap, a really practical gap in terms of the time and energy that it would take somebody to travel for an appointment. Yeah, and we heard people saying to it helped facilitate their own self-maintenance of their own health, right? And so being able to not say, I'm going to put that off because it's so inconvenient for me to have to take time off work to go see the physician, being able to have that virtual contact, and then, with improved health outcomes, if people are able to engage in their own health behaviors more directly, then seeing that impact for specialist care too. Great. I see a question here for Dr. Moss. Are there plans for the hub that Dr. Moss, my screen just jumped, spoke about to incorporate proactive social media messaging through the popular channels that Dr. Boucher's work identified, nipping those negative, non-evidence-based messages in the bud? Comment, I am thrilled at the breadth of the work presented this morning. Thank you for that comment. Dr. Moss, did you want to respond?
Yes, absolutely. It's a really great question because we get all this research and we have all our findings, but as we said earlier, so what do we do next? And how do we pull this all together into something that's actually impactful for not only adults, but youth and their families as well? So in particular to youth and families, we do have quite a neat plan. We just submitted an application as my first grant that I wrote with my supervisor, Dr. Gina Personsley. And it's taking all of the findings that we found throughout the pandemic on how social isolation has really impacted kids and youth, and it's taken a devastating toll on them. And there are fewer opportunities to engage in protective activities such as physical activity. We know that this is likely to have a really detrimental short and long-term effects on youth. And we also saw that there was a massive shift, as was presented this morning, towards digital health. But there were concerns that those tools or those apps that were presented on earlier, these were not rigorously co-designed with youth and their families, and only addresses mental illness as opposed to acknowledging periods of poor mental well-being. So it takes on a more of a pathologized approach. So we've partnered with youth and family organizations across Canada, as well as a few different teams who have expertise in creating digital tools to create a psychoeducational digital tool for mental well-being support to be delivered virtually to really increase access, especially to marginalized youth and youth living in areas with limited access to in-person services. So that's one application of all of this work, and how we're going to build something that is tangible, accessible, and actionable, really, for moving forward from pandemic recovery.
Great. I'll maybe pose this next question to Dr. Ahmed. Good morning from India. Very nice that we have people tuning in from all over. My question is in the context of impact of COVID-19 on women. Here, impact has been mentioned on women in general in Canada. Being a resident of Eastern world, I was curious to know about the factors that can be peculiar to underdeveloped countries in the context of impact of COVID-19 on women healthcare workers. I know that your work is localized, but any thoughts or comments on some of the nuances or differences that we might anticipate in other parts of the world?
So first, thank you for that question. And I recognize it must be fairly late at night. So I think that's great. So initially, we actually had hoped to get a global response to our survey. It's to answer exactly that question. And probably just by virtue of the fact of the vast majority, not all of our collaborators were located in Canada. We ended up mainly getting Canadian respondents, so did have 1,000 respondents from around the world. But because they came from such a scattered area, our survey was in 6 different languages, that we decided, for the purposes of at least putting out the paper focusing on Canadian healthcare workers. So the limitations with what we did, our results, what I just presented, is exactly as you pointed out. It's perhaps not generalizable. It's not to everybody. Canada's a high income country with universal healthcare. And I think that there are some commonalities. So I'm not a social scientist, but I have learned a tremendous amount. And so there's increasing work looking at, especially in the pandemic, societal expectations of what a healthcare worker does, and which are oftentimes in direct contrast to societal expectations of what a woman and a mother in particular do, and they just don't mesh. And that differs across cultures. And I think there are some universal truths in that too. And I had mentioned earlier that the majority of the world's healthcare workforce are women, many of whom are mothers, not all. And so I think it's important. I think there are learnings that we can all take from the study, recognizing that, they differ depending on which setting and what resource availabilities are around. But that's an excellent question. And I think the next study should be looking at a more global response, or actually more country specific, because at the end of the day, we all have our own governmental policies, et cetera, that are local, and we need to incorporate this. So I'll stop there.
Very important point in terms of how political will and government politics can really influence our responses. Yeah. Thank you. There's 2 general questions here that I'm fascinated by and really curious to hear your thoughts on. I'll start with this. What are the steps to creating policy change following the publication of research? How does the body of literature need to get, how big does the body of literature need to get to start influencing policy? That's a big, important question. And I'll just open it up to any of the 3 of you who would like to start us off.
I think we're all trying to avoid the big.
It's a big question.
I think probably having the more, if you can engage, and I'm not saying anything that this audience is well aware of, if you can engage people who are interested in the results right at the beginning, and they're part of the research team, like who your knowledge users, and Pam, you talked about improving patient outcomes in the Indigenous community, like making sure that what you're studying is something that actually matters to people. So having, your people with lived experience and people who will hopefully benefit from the results as part of the research team. Easier said than done in all settings, but that would be my thought. I'd be interested to know what Dr. Roach and Dr. Moss think.
It's a big, complex, important question. Yeah, and Dr. Ahmed, you you really touched on what is so important of us as researchers. So while practice and policy changes, those are critical deliverables for a lot of our research. One strategy that we've found most effective in qualitative research is the use of personalized stories and experiences to really humanize that research. So understanding on a human level the interactions between barriers and facilitators of change for key vulnerable subgroups of people. This is really effective, an effective approach to developing evidence-based interventions and recommendations for policy and practice. And really, I think it comes down at the end of the day, the key part of intentional policy change is getting the public on board. So effective knowledge translation is particularly critical for this. And as we've seen throughout the global pandemic, separating politics from public health agendas, this is really key to safeguarding trust and confidence. And at the end of the day, it comes down to how we implement that effective policy from the research we're conducting.
Mm-hmm. Yeah. Go ahead.
Yeah, so I think as well, I think it's important to think about the audience, right? And when I'm thinking about like actually impacting policy, you're thinking about the outcomes, right? So when you're thinking about the kind of work that you do, thinking about the outcomes to the people it matters to, but then the way that you demonstrate that is thinking about that audience. So if I'm looking at developing innovative dementia care interventions, well, I want to make sure that it's effective for the people living with dementia and families, for example. But then I'm thinking, well, then how do we get it funded? Who's the audience for this work? And all of that will then impact the methods that you do, right? So who's involved in your team? Do you need health economists? Do you need implementation scientists? And so I think it's not so much that how do we get it to change policy after publication, but it's how are we going to impact policy from the start? And sort of who are the people that we need to have relationships with to be able to think forward to how this might change policy.
Mm-hmm. Thank you, all of you, for that. I'm gonna take a liberty and pose one more question because it's another big question and it's one that I grapple with all the time. So really curious to hear your thoughts about this. How do you handle or deal when your recommendations are not taken into account due to policymakers' political conflicts? How do you handle both getting policymakers to listen and the frustration of politics getting in the way of science?
Katrina, you ask really hard questions.
I can't take credit.
We can all agree on that.
I can't take credit for these great questions.
I can talk about I'll say personal, that's not the right word, but as everyone knows, there's been a change in leadership in Alberta Health Services recently, and the previous leader was quite interested in the results of the study that I presented before. And sort of had to start a little bit from scratch, given that there's a change in leadership, and that's, changes in leadership happen. And so just to allude to a point you made earlier, there's different political will and different, areas of priority. And so I think you just try and make what you've found align with that person's priorities and try and work together with whoever happens to be in that position. But it's not an easy task, depending on whatever. Anyway, I'll stop. So thank you.
Yeah, it's not an easy task at all. Hey, I would say, I think about this a lot. I think working in Indigenous health, we can look at the TRC even as like a really big set of recommendations, right? All those calls to action and how many are actually being answered. And so I think to address that bit about how do you, when things aren't being implemented, how do you kind of keep pushing forward and keep the momentum and deal with the frustration? And I think for me, it's a real commitment to believing in the effectiveness and the efficacy of what I do, and continuing to fulfill those obligations. And so also knowing that people, as Sofia already mentioned, people leadership in different places changes. And so you can keep doing the work, keep building those relationships with communities and other research partners. And you just keep doing the work, and then keep trying to demonstrate that it is a priority, and all of those things that sometimes decision makers look for, return on investment and those kinds of things, trying to link to those concepts and show the value of what you do. And then eventually, hopefully, somebody who prioritizes that kind of work will recognize that. But I can speak to that, sort of like, how do you keep going when things don't get taken up? And it can absolutely be, it can be hard, but if you know that it's important and you can see that there's value, you keep going. I don't know if that's super helpful in the long run.
It is helpful. And every once in a while you get a win, you know, you have that moment where something really amazing happens, and that's what makes it all worthwhile. Dr. Moss, did you want to comment?
Sure. I mean, when we are attempting to solve a problem as a group of researchers, I think we can all agree that we wish there was one perfect solution, but there's rarely a simple solution. And, you know, oftentimes there is a bit of a disconnect between those doing the research and those attempting to pass policies. And we've seen that with the absence of a perfect solution, it's really hard to get constituents to actually adopt that policy. So finding alternate avenues of dissemination is really key when things don't go as planned, or our research isn't implemented or impacting the people that we want it to, and we know it should. We know, again, as researchers, we know that linear models rarely address the multifaceted nature of healthcare issues, but they're often easier to comprehend and implement. So it's really everyone's favorite word throughout the pandemic, pivoting to find something, another way, another avenue to disseminate our research. The COVID-19 pandemic was a really perfect example of this. It's challenging to propose evidence-based policy changes when, as researchers, we're all still racing to understand the true nature of the problem.
And fighting against public messaging, political will, and social media conversations. Yeah. Well, we should probably stop there. Honestly, I could have this conversation with all of you for the rest of the morning. I just want to thank you so much. Your presentations were amazing, but the opportunity to have a really thoughtful, meaningful conversation about what it all means, specifically in terms of why we do this work and why it's important to think about the implications of our work in relation to policy and practice. So thank you so much to all of you. It's been a great way to start off our discussion this morning. I'm sorry we weren't able to reconnect with Dr. Boucher, but I think at this time we are ready for a break. If I'm not mistaken, someone pop on and tell me, oh, there we go, break. So if you take 10 minutes and we will reconvene and be very excited to hear from our next set of panelists. So thank you again, everyone. And thank you for the very thoughtful questions. See you in a few minutes.